Well, thank you, Rob. Ladies and gentlemen, my task today is to talk about the use of point-of-care assays in patients undergoing PCI. These are my disclosures. And I'd like to start with a case which is a 62-year-old male who happens to be the director of a referring hospital and who has had stable angina for a year now when he was admitted to the CCU with unstable angina. He had been treating already with aspirin, low-dose aspirin, and he was loaded with a bolus of 600 milligrams of Clopidogrel and was scheduled to undergo coronary angiography the day after. And the question is, should we use platelet function tests in this patient? And I think there are three good reasons why to use platelet function tests in these patients. And the first one is there is a marked interindividual variability in baseline, say intrinsic platelet reactivity. Now that's, for instance, shown in these classical studies from the 1990s, showing patients who survived a myocardial infarction who demonstrate high aggregation, so positive spontaneous platelet aggregation, do significantly worse over a follow-up for 5 years than patients who have, say, normal platelet aggregation. So intrinsic platelet aggregation seems to matter for the outcome of these patients. The second reason why to measure platelet function in these patients is because there's a marked individual response to antiplatelet drugs. For instance, shown here in the classical study by Hochholzer, demonstrating that some of the patients have a poor response to the same loading dose of Clopidogrel. So if patients do not respond, it might be useful to measure platelet function. The third reason why to measure platelet function in these patients is that, say, the one-size-fits-all regime, which is dictated by the guidelines, is not good enough. It's, for instance, shown in randomized trials like the Triton and Plato with the stronger antiplatelet agents like Prasugrel and ticagrelor. The thrombotic event rate during follow-up is still 10%, so it's quite high, and I think we can do better for our patients. Another observation we did in our Dutch stent thrombosis registry was that 70% of those patients suffering from stent thrombosis are on aspirin and Clopidogrel. So if we measure platelet function, what exactly should we measure? And I'd like to make a plea not to measure response, but measure on-treatment platelet reactivity. And I'll show you why in this very simple graph showing the platelet reactivity in 3 patients, A, B, and C. And as you can see on the right-hand side, high on-treatment platelet reactivity is the highest in patient A. However, the response to Clopidogrel in this patient is also the highest. So it's only because of his high baseline platelet reactivity that also his on-treatment platelet reactivity is the highest. So I think we should measure on-treatment platelet reactivity. It also gives you the true magnitude of platelet reactivity at the time of the PCI, and it is logistically possible. You only need one measurement. This slide has been shown already, showing that there is an association between high on-treatment platelet reactivity and clinical outcome. However, there are some drawbacks to these studies. One is that the sample size of most of these studies is rather small. Maybe more important is that they use different cutoff levels for their tests, usually the upper quartile of platelet reactivity, and do not use proper receiving operating characteristic curve analyses. And very importantly, in all those studies, only one test was used, so there's no comparison between tests. And therefore, we performed the popular trial, which was published last year in JAMA, in which we incorporated most of the, at that time, available platelet function tests, which is light transmitters aggregometry, which is sort of the gold standard, but it is laborsome. You need trained technicians in a dedicated lab, so you can't do it in a cath lab. We use the Verify Now P2Y12 assay, which is fully automated, is also aggregation-based. It's based on whole blood, and it can be done in a cath lab. We use the Platelet Works, which is also based on aggregation, based on single platelet count, without and with ADP stimulation. It has one restraint that you have to perform the test within 10 minutes of blood withdrawal. We also included two tests which are probably more physiological because they include shear, and that's the Impact R and the PFA 100. Also including the new Innovance PFA test, which is fully dedicated to measure the response to Clopidogrel. And I'll show you the results of the popular study in over 1,000 patients. And this is the Kaplan-Meier curve of 1 year follow-up, showing that those patients with normal platelet reactivity in blue do better than the ones who have high platelet reactivity. And that's true if you define high platelet reactivity by 4 tests. And that's light transmitters aggregometry, whether it's with ADP 5-molar stimulation or 20-molar stimulation. That's the Verify Now, that's the Platelet Works, and that's the Innovance PFA. So the other 2 tests were unable to identify those patients with the highest risk based on high platelet reactivity. In the meantime, there have been several other studies, and there's now consensus on the cutoff values based on ROC analyses for 4 tests. And that's the light transmitters aggregometry, the Verify Now, the VASP assay, and the multiplate. So now that we know what to measure, which is on-treatment platelet reactivity, and that we know that there are tests which are validated and are able to predict outcome, why would we use these tests? Well, one reason might be that we know that patients who have high platelet reactivity, despite aspirin and clopidogrel, have a higher risk for per-procedural myocardial infarction. And it has also been shown in small trials that adjusting the medication based on these tests, for instance in the Bonello paper, the adjustment was done based on the VASP assay, and patients were reloaded with a 600 milligram loading dose of clopidogrel until the VASP assay had normalized. And it was shown that patients in the VASP guided group did significantly better, with only 1 event at 30 days versus 19 events in the control group. Another trial randomizing patients to additional antiplatelet treatment, in this case tirofiban, a 2B3A inhibitor, in patients with high platelet reactivity despite aspirin and clopidogrel, showed that those patients did significantly better with respect to per-procedural myocardial infarctions than placebo. So there are small trials looking at the effect of additional treatment to prevent per-procedural myocardial infarction in those patients undergoing PCI. So what about the long-term effect? We do not know if we change the medication based on these tests that we will influence and optimize the outcome of these patients. But what is a very striking observation is that if you look at the results of testing in the patients, say the daily-to-daily patients, about 75 of those patients have normal platelet reactivity based on these tests. And these patients do excellent. They have a very low thrombotic risk during follow-up. So it's probably of no use to switch those patients to a stronger antiplatelet drug. It will not reduce the thrombotic risk, and it will probably increase, as you've heard from the previous speaker, increase the risk of bleeds. So that leaves you with another about 25% of our patients who have high platelet reactivity, and again, we do not know if we change the medication based on these tests that we will improve outcome. But intuitively, it is the right step. And we do know that there are drugs which are effective even in patients who have high platelet reactivity. So this is the response to Clopidogrel on the left-hand side, and it shows you if you switch those patients to Prasugrel, even the patients who have a low response have a perfect response on Prasugrel. So we have agents, Prasugrel and ticagrelor, which are probably effective in patients with a low response to Clopidogrel. So let's go back to our case. This patient underwent angiography the next day, and he was shown to have 2-vessel disease, a short lesion in the right coronary artery and a bifurcation lesion in the mid-LAD and diagonal. At the table, this WISE director, and that's as you know, it's unique that this patient is a wise director. Also not to perform CABG and measure platelet function. And he turned out to have a PRU measured with the Verify Now of 245, which is above the cut level we found in the popular trial of 236. So this patient has high platelet reactivity. We also measure a risk score, which is the popular risk score in our hospital, which is a composite of platelet aggregation, as you can see on the slide on the left-hand side, but also genetics and clinical risk factors which are predictive of worse outcome, especially diabetes and a diminished left ventricular function. And this patient had a total risk score of 3.5, which is above the cut value of 2. For both reasons, this patient was treated with a 2-beta-3 inhibitor, probably to reduce the per-procedural myocardial infarction risk. Subsequently, 3 drug-eluting stents were implanted, 1 in the right coronary artery, 1 in the LAD, and the 3rd in the diagonal branch, with a good result. His CK leak after the procedure was slightly elevated, and this patient was treated as an outpatient clinic with low-dose aspirin and Prasugrel 10 milligrams per day. And he is uneventful 3 months afterwards. So, in conclusion, I think we have to wait for randomized trials, especially for Arctic, to prove that using platelet function tests in all our patients is meaningful. But in the meantime, if we measure platelet function, I think we have to measure on-treatment platelet reactivity. And we have to use one of the ROC-validated tests. I think it makes sense that to leave all those patients, the majority of patients, about 75% of our patients, with normal platelet reactivity, which have a low risk of thrombotic events, on low cost and safe Clopidogrel, and that leaves you with the 25 patients with high platelet reactivity. It makes sense to use a stronger antiplatelet drug in those subgroup of patients, but again, I think we have to wait for the randomized trials to adopt this strategy. I thank you for your attention.
Time for a quick question if anyone wants to. So a bit of uncertainty perhaps about the mechanism of mortality reduction with ticagrelor compared to clopidogrel. Does that influence how strongly you feel about this sort of strategy of testing on clopidogrel compared to using alternative agents upstream?
Well, I guess maybe not the uncertainty, but the flip side, as you demonstrated, is still with ticagrelor, especially in those patients not undergoing CABG. The event rate of bleeds is still higher. And therefore, I guess that it is the same with Prasugrel. We can use those platelet function tests and not treat all those patients with ticagrelor because of reducing bleeds, especially in the low-risk patients.
One question.
Anderson, U.S. Very nice presentation. Recent reports suggest there may be a proportion of patients even on Prasugrel from Dr. Bonnell, in fact, that in fact shows suboptimal response. And the other question on the other side, is it possible to have too high platelet inhibition, so to low platelet reactivity units, and one might down titrate, for example, on Prasugrel and decrease the bleeding risk into, let's say, a range of 100 to 200 or so PRUs. Any thoughts on that?
Yeah, but absolutely right. One remarkable thing I noticed is that if you look at the response to Prasugrel, as Rob, for instance, showed, in the acute phase, it shows that all those patients respond properly to Prasugrel. But if you look at the 30-day results, there are more patients not responding to Prasugrel than in the acute phase. So the platelet inhibition of Clopidogrel and Prasugrel, it comes close together after 30 days. So that makes intuitively, again, the issue of measuring platelet function also on the long run. And your second point is well taken. I think there is an optimal range, and there has been papers, especially from Sibbing, showing that those patients who have a, say, super normal response to antiplatelet therapy are the ones who bleed more. So I think we should aim for this target between bleeding on the one side and thrombotic risk on the other side.
Okay, thank you very much indeed. I think